of our online phytomedicine programs. Today, we're going to have two speakers, which is Professor David Katerere and will be Dr. Saida Yasmin. As the first speaker, Professor David Katerere is the research platform chair of pharmaceutical and biotech advancements in Africa at the Tshwane University Technology in South Africa. He is the co-director of the recently established CSIR and TUT Cannabis and Hemp Research Center. In this capacity, he provides contract extraction and formulation service for farmers and entrepreneurs in South Africa and in the SADC region. He is a co-inventor of the nutraceuticals Nicelo and Semba, which provide wholesome evidence based on nutritional nutrition and are commercialized for the market in Botswana and South Africa. So more recently, the products have been licensed in BioGo in Scotland for entering the UK and Kenyan markets. Lastly, he is the co-editor of several books, including the African Herbal Pharmacopoeia, Onto Veterinary Botanical Medicine, System Analysis Approach for Complex Challenges, and Traditional and Indigenous Knowledge for the Modern Era. Welcome again, Professor David Katerere. We are really happy to have you among us today, and we look forward to your presentation. Floor is yours. Thank you.
Merci beaucoup, and thank you very much for giving us this platform. So I'm going to share. Okay, you can see my presentation?
Mm-hmm. Yes, we can see your presentation.
Okay, thank you very much, and for the kind introduction. So, as you can see, I'm at Tshwane University of Technology and also the co-director of the TUT CSIR Cannabis Research Hub. So this evening, I've been asked to talk about medical cannabis in the context of chemistry, extraction technology, some preclinical research, and then formulation. Yeah, so maybe for those that don't know this, Africa, and particularly Southern Africa, is actually leading in terms of cannabis and hemp licenses and permits in Africa. As you can see, it started with Lesotho, and I was in Lesotho 2 weeks ago, and I can tell you they have really good product as well. And it started in Lesotho back in 2017. And now they have about 25 licenses, probably under 10 of those are operational. And they don't distinguish between hemp and medical cannabis. So I think the industry is quite well established. They have some teething problems there. And then rapidly followed in this evolution by Zimbabwe and South Africa. And at the moment in South Africa, we have over 100 licenses. So South Africa, Zimbabwe, and a lot of other countries actually distinguish and separate medical cannabis, hemp, and then recreational. In the case of South Africa, it's the only country actually in Africa where it is legal to grow cannabis for adult use, as we would call it. So about 100 medical cannabis licenses, probably about 5 to 6 are operational at the moment. And then we have over 1,100 hemp permits, of which my university holds 2 permits, actually. So we have a research permit and we have a production permit. And as you can see, lots of other countries coming online. But why Africa? Well, we have things here that maybe they don't have in other parts of the world. So we have probably the largest tracts of arable land in the world, as you may know. And we have sunshine, our labor is cheaper. And in quite a lot of these countries, there's tobacco growing expertise. And if you can grow tobacco, which is a very sophisticated crop, then growing hemp cannabis is a walk in the park in some instances. But there are threats, obviously. The fact that we have synthetic cannabinoids is an issue, bureaucratic delays, and just general confusion sometimes between hemp and cannabis, right? So maybe a little bit of an introduction as to what we do. So we have some research and development activities. We are a University of Technology, and my own personal philosophy is that we should teach and practice and put products on the market. And I will show you some of the work that we are doing. So we have a CO2 extractor, the only one of its kind actually in South Africa at this stage. It's a pilot size plant. And so we offer this service to license holders across the region. So in fact, we're in the process of importing material from Zimbabwe for a grower there, and then we would fractionate that, extract that for them. So at the moment, I think we've serviced about 20 farmers and growers in the past year or so. The other service that we offer is cultivation. So working with students from crop science, but also students from pharmaceutical science. We actually assist farmers to set up and grow hemp. As you know, hemp is a broad acre crop. So in this case, this is a farm just outside Johannesburg. This is when we started out about 3 months ago. We are now at the point of actually harvesting. And then we can do all sorts of things. In this case, it's a chicken farm. So they're interested in us formulating or helping them to formulate chicken feed. We also do a lot of training and advocacy. This is in Limpopo. Dr. Bilinga there, she came with us. We were launching the hemp forum in one of the villages. This is our collaborator. He's a doctor in the mines, and he also grows cannabis, and we work closely together in terms of clinical validation. And I'll show you some of those results. This is Dr. Lechaba, our project manager with the Minister of Health, Minister of Science, Technology, and Innovation, Dr. Zimande, and just showing him some of the industrial products that come from hemp. And then we do formulation and clinical testing. As you can see, this is the green gold from the flowers, and then we formulate it into oils and creams, and then test that. And I'll touch just very briefly on the results that we're getting, because the purpose of this talk is more upstream. Okay, basic botany and phytochemistry, and I apologize in advance because I know I'm talking to experts, but that's what I've been told to talk about. As you know, we have cannabis sativa, indica, and ruderalis, and quite distinct from the morphology of the leaf and also from the height of the plant. And so we tend to work in the sativa indica areas, but we are also looking at land races. So my trip to Lesotho was actually to collect some land races that we then want to look at. And you may know that these plants occurs male, female, and hermaphrodite. So it takes 3 to 4 months for them to grow to maturation. From the chemistry perspective, this plant has over 550 different compounds, and I've highlighted here the secondary compounds, right? Secondary metabolites. So over 140 cannabinoids, and new ones are being discovered all the time, of about 120 terpenes and terpenoids. And when you talk to the cannabis people, it's like they've discovered terpenes. But we know that terpenoids are very important metabolites, and they've always been around. Some of them very important medicines, actually. And then what is little known and little studied is phenolic compounds. flavonoids, canaflavins, so about 46 of them. Obviously, this is just dependent on the phytochemistry work that's being done, and also in terms of the proportion of compounds, because as some of the phytochemists in the room will know, you generally are all only able to isolate the major compounds. Alkaloids, they are also alkaloids, and this is something of interest because we know that alkaloids make very good medicines. They also make very good poisons. And then, of course, there are all these uh, primary metabolites. So a very, very interesting plant from phytochemical perspective, and definitely one worth studying. Then when we were zooming into the cannabinoids, which is what everybody wants to talk about, you can see here the biosynthetic pathways, right? That at the center of all of these, the mother is really CBG, in this case, the acid form. And then, it can go into THC, CBDs, CBCs, and therefore to the world of cannabinoids, where you have all of these, and they have different pharmacological effects, which we will not get into. So if you're interested in this, you can go to cleantrials.gov, and there you will see, the last time I checked, there were over 308 clinical trials going on in the world. And I can tell you there's nothing else that is more studied at this stage. I can't think of any other product that has so many clinical trials going on. So interesting. So let's go to the extraction techniques then. So we like to talk about solvent extraction techniques and solventless extraction techniques. And in solvent, it's mostly ethanol, right? Just to keep in mind that when you are extracting something for a pharmaceutical product, you don't become adventurous and use all these other organic compounds that phytochemists like to use, like hexanes and methanol. Even though when I was at the University of Mississippi, they were actually using methanol. The problem with us would then be the residual solvents. And as you know, methanol is quite toxic. So when you use ethanol extractions, which you can do at benchtop, by the way, um, it is fast, it's easy to use. It can either be mechanized or it can be very artisanal, right? Which is good. The problem is that you're also extracting chlorophylls and your product is quite bitter. Um, so people use it for tinctures and edibles because it's really the recreational market that's doing these kind of things. Just note that I don't promote edibles, and this is from my work as a pharmacist and also as a regulatory scientist. In South Africa, this is a very controversial area. And a few months ago, the minister actually banned uh, all cannabis edibles, and then as a result of pressure, unbanned. But I can tell you that the ban is again around the corner. I'll talk about it a bit later. And then you got hydrocarbon extraction. So this is good for preserving terpenes, but you see, residual solvents become a problem. It's used for shatter, wax, live resin, and this is actually mostly for the recreational market, which again, we try to stay away from. And then we got supercritical CO2 extraction. This is expensive equipment, but by the grace of God, we managed to get one for ourselves. So we actually have this instrument, and it makes pharmaceutical grade extracts, and we will talk about that in a minute or two. Then what's called solventless would be, actually, this is just a physical press. So obviously you have low yields, good that you have no solvents, but this is used in the recreational space. And then increasingly there's this ice water hash, or bubble hash, as they call it, also very popular in the recreational space, but it's also now being used industrially. I have also here marked these things green because they are environmentally friendly. So when we then talk about industrial extraction, we really mainly use the two methods, ethanol extractions on the one hand, and then um, CO2 extractions. And this is a process you'd follow. The drying, for CO2, we want our water content to be below 10%. Milling, we have to mill to a particular size. We actually do the sieving ourselves. So when people bring their product, we tell them not to mill the product, just bring it as dry, and then we do the milling. And then we go through extraction process. Then there's this winterization. And again, this is language that, people in the cannabis industry would claim they have invented, but we do this all the time, right? We use temperature to separate out aqueous phases from liquid, rather fat phases. Typical first year chemistry, standard extraction. And then we do want, from an industrial perspective, to um, recover the solvent because that's your pinch point from a cost perspective. Then you want to decarboxylate because actually it's decarboxylated compounds that are active. After that, you can do the distillates and also do the isolation by crystallization. But the extract itself can be used already, and I prefer to use the extracts in many cases because then you have these synergistic effects, which again the cannabis people like to call entourage effects. Okay, so when we focus on supercritical extraction, this is really so you can see here uh, there's pressure versus temperature. So as you increase temperature, obviously of a substance, it vaporizes and becomes a gas, right? But if you then increase pressure, you then create this supercritical phase where the gas actually liquefies and acts as a liquid solvent. So that's what you're doing here with CO2. And then this is a schematic of the actual instrument itself. So the important thing is that you have chillers. There's obviously an energy element to this. So that's why using ethanol is easy because in particularly in Africa, we do have energy poverty in the sense that we don't always have electricity on demand. And then you also need CO2, so that has to move around, right? This is an ethanol extraction system. So you just take fresh ethanol, right, at ambient temperature. If you're then doing this in a automated way, you actually chill the ethanol, right, cryoethanol, and then it's better able to extract. And then you can filter and recover uh, the ethanol itself. So when we were thinking, and these slides, by the way, full disclosure, are from our supply of equipment, because when we were thinking about setting this thing up, we looked at the advantages and disadvantages of ethanol. We were just coming out of COVID. There was a lot of ethanol floating around, which actually was contaminated with methanol. And we definitely didn't want anybody going blind or to kill people. We also really wanted something that did not have the dangers of explosion. If you look online, a lot of these ethanol plants have actually gone up in flames. There's also the issue here of waste management. So with ethanol, you have to think about where to store the ethanol, and then you have to also think about where to store the waste of the ethanol. Whereas with CO2, despite it being expensive, the actual operational uh, expenses are quite low. So you can see here head to head between CO2 and ethanol. So from a capex perspective, ethanol is cheaper, but from an operational perspective, you will see that CO2 is cheaper. The quality of output, definitely CO2 is fantastic. You actually get two products out of CO2. So the actual oil and then the spent biomass. And I'll show you a bit later that we use both actually. And at the moment, our facility is zero waste. So we use pretty much everything. Some of it we use it for bioplastics, or we're using it as for mushroom media. Extraction efficiency, yes, CO2 does tend to pull out more, but it's got its disadvantages. Flexibility in process, ethanol here is more efficient, but CO2 from an flexibility perspective and also from compliance, right? The only risk here is pressure. So every year we bring in people to do pressure testing. No real risk of fires, so I can sleep well at night. Uh, Ease of use and maintenance, yeah, ethanol is good. In terms of skilling people, you don't need that much skill to run ethanol. We're doing it. You can do it benchtop, as I said, and then of course scalability. It is quite scalable. But when you look at post-processing, so in terms of CO2, it then goes through the winterization. Winterization is just chilling, really. So if you remember in chemistry, you would take maybe water and then hexane, and you'd put them in a chiller, and then the water would freeze, the hexane wouldn't freeze, and then you just separate those things out. So that's simply winterization. Solvent recovery, decarboxylation. Whereas on here, you have less steps because you're using chilled ethanol, right? But when you look at it, you have better control with CO2 than with ethanol. You have more SQUs that are possible, right? Whereas ethanol tends to have a lot of unwanted components, like we said, chlorophylls, for instance, which you can use. There's a market for chlorophylls out there. Better quality due to targeted extraction. As we said, the issue here is your ethanol pure? And what are the residues that you'll need to think about? So that's a big compliance issue as well. Right, let's talk about formulations then. So in terms of formulations, you can have oral formulations, you can have topicals, you can have injectables, inhalables. So those are kind of the four things that we can focus on. So in terms of oils and tinctures, it's mostly using other seed oils or fixed oils. So you can use hemp seed oil, olive oil, and that advantages are that then you put it under the tongue, sublingual, which is not as easy as it sounds actually. So normally I say to people, put it on a teaspoon and just hold it in your mouth. And examples of this are Sativex. Epidiolex, I was surprised. It's a big issue because we have epilepsy is a big thing in a lot of countries in Africa. And obviously, epilepsy, unfortunately, is considered a disease of the poor. So that's why I'm a big believer in cannabis, because it's really a game changer, because the formulations are very simple. If you look at the Epidiolex formulation, extremely simple. And these are some of the things that we need to be doing for our people, right? Um, and soft gel capsules and pills, so cannabinoid dissolved in oil, and then gelatin. This technology is very difficult for us in Africa. However, what we find is that we can actually make, from the spent biomass, we actually make something called canaringa, which is a capsule with cannabis and moringa in it, and very good for anxiety, sleep, and you sleep better, but you wake up with energy. So we've got some real good real world evidence to support Kanaringa, which when you look in the literature is a totally interesting and very unique product. Then, of course, you've got emulsions. There are pharmacists in the room. You know how to make emulsions, right? Um, I know that there are also people doing these nano emulsions. But then a lot of people who are using cannabis are attracted to cannabis because they want natural products. They don't then want you to go in and start doing nanotechnology type of things. I mean, that's a different kind of audience. And then edibles. So edibles are very simple. You take your flower and you infuse it in butter, coconut oil, whatever. And then you make your gummies, chocolates, baked goods. Dangerous as well. Particularly the ones that you buy in these dispensaries. Because one of the biggest problems that's happening in this space is uh, Delta 8 THC, which occurs, you'd have observed much earlier, in very small quantities, but now there's synthetic Delta 8 THC. So, for instance, at the recent Cannabis Expo, people ate edibles, and in one day, 9 of them had to go to hospital. And I know that last year, I think at the MJB's meeting in the West Coast, I think it's California, that the meeting had to be closed prematurely because people were just passing out. So, word to the wise, do not buy things that you don't know, and especially in these dispensaries. And in fact, some of them are laced with illicit uh, opiates. So just be very careful. If you have to do this, come to me. I'll be happy to supply you with the material. And then in terms of inhalables, right? Smoking obviously is a traditional way of doing this. And actually, they say cannabis was first smoked on the African continent. So, yay, that's one of our inventions. And then the thing is, issues around bioavailability come up. Also, then, smoking is not a good thing, we know. There's tar going into your lungs. Vaping. So there are lots of vaping devices out there, and vaping is very popular with young people. The fear that I have is things like pneumonitis, because as you know, your lung lining is not supposed to be disrupted by oils, and now you're taking in these propylene glycols and glycerines. So this is not a very good idea at all. This might be a good idea. So dry powder inhalers still under research, and maybe the use of asthma type of inhalers. Right, moving quickly along. Creams, lotions, and balms. Galenicals, so these are very easy for pharmacists to be able to formulate. And in fact, we have formulated some products for one of our clients, Dr. Shavani. So Dr. M, this is his brand, and also Lunako, this is his brand. So they have all sorts of applications: pain, inflammation, hair repair, uh, uh, fungal infections of the skin, all sorts of things. If you want to be more sophisticated, there are also transdermal patches that are coming, and lots of work going into this, particularly for diseases like epilepsy. But these are actually more expensive than just oral formulations. Some of the work that Dr. Shavani is doing in the mine. So miners are prone to fungal infections of the skin, feet. In this case, tinea pedis, and you can see apply Lunako within 10 days. This is what we have, right? Tinea cruris here, applied, and good outcomes. So terbinafine is standard treatment, small tubes, and we calculate that if you have to treat these patients with terbinafine, you'll need over 12 tubes because you have to treat it over maybe 6 weeks, 8 weeks, 12 weeks. right? So actually, it's over 2,000 rand, right? Uh, divide that by 20, that's about $100, versus $15 for this treatment over 10 days. People can get back to their work. Um, these are real world cases of treatment of acne. You can see here and over there, and eczema within 14 days. Okay, I had 30 minutes and it's I'm at 30 minutes. So we work a lot with B2B. As I've already told you, we don't work in the recreational space. So we, for instance, two months ago now, we had the first kind of Connect event in South Africa, and next year we'll be having that. And this is really around medical applications, market barriers, and working within the region, the Southern Africa region. I also co-edited this book about 15 years ago. And increasingly, I'm interested in ethno-veterinary use of cannabis. At that stage, we couldn't talk about cannabis at all. So we had a lot of other products, but dogs suffer anxiety a lot because a lot of them are spending time like humans locked up. So again, we are looking at developing products in the veterinary space. This is our last book. So this is from 2019, Traditional and Indigenous Knowledge for the Modern Era. In 3 months, we have a book coming out, which is the African Herbal Pharmacopoeia, the second version. This is my email address. Feel free to contact me. And with that, I'd like to thank the moderator and hand it back to you.
Thank you very much, Professor Katerere, for these very great presentations. So what I suggest, we will go with the second speaker, and then we'll go to the section of questions. So to all our participants, please write the question in the Q&A sections while I introduce our second speaker. Our second speaker is Dr. Saida Yasmin. She is a full-time instructor under the Radiation Oncology Department at Harvard University, and she is also a researcher. Just to give a brief overview of Dr. Saida Yasmin experience, she held a medical degree from the Chittagong Medical College. She then went and obtained a master in immunology from Long Island Universities. Also, she has a PhD in chemical engineering, which she obtains at the University of Rochester. Dr. Saida Yasmin has been heavily involved in cancer research that span, as you can see, from the phytomedicines, nanomedicines, and radiotherapy. And she will be presenting on us today on the utilization of cannabis for cancer care. Thank you, Dr. Saida Yasmin. The floor is yours.
Thank you. Can you see the slides?
Yes, you can see the presentation.
Okay. I do see a slide in the middle. Anyway, so thank you very much
Sorry,
for
Dr. Sayeda, will it be possible to have it as a full screen because maybe the
yeah,
text
this
will be
is
too small?
something I'm trying to get it to full screen. Can you see it now?
It's loading. Something is loading. Maybe a minute.
Let me go again. No. I did not ask for the notes.
Okay, you maybe go to display setting.
Screen. Presenter view and slide view. Can you see now?
Yeah, we still see the things at the bottom. Yes. Yeah, but it's still not as a full screen.
It's not showing full screen.
Yeah, okay, 1 minute. No, it's not showing full screen. We still see the next slide that is appearing into the viewer mode.
Is it possible? Can you see now?
Yeah. I see it on my hand now as a full screen, but I don't know if that's the case for everyone.
Later. Should I go now?
Yeah, we may start, I think. You can see.
Hi everyone. So my topics today is cannabis for cancer care, and I am presenting some. We learned a lot about cannabis few minutes ago, so I'll just brief introduction to the cannabis, which I found in the American Cancer Society website, where they describe a short, brief description of cannabis, which is a group of plants and in the cannabis family. There are more than 700 varieties or strains of cannabis, specific parts or chemicals found in cannabis plants. The different terms used for describe the cannabis can refer to different types of cannabis plants. So understanding of the different names of cannabis we can be used in different specific treatment or some cancer care uh, activities. So for okay. So there are some benefits for the cancer patients, which shows as a palliative type of care and as well as effective as anti-cancer progression or anti-cancer treatment, reduces cancer progression and increase the of livelihood or survival duration in different animal models, which has been shown. And as well as it also has been shown that this treatment with combination of different other therapeutic models increase the survival duration of animals. So in here, I will show some of the study our group has been done in cannabis, which includes CBD, uh, caflanon, hesperidine, and myricetin derivative Linebacker one. So at first we talk about the cannabinoid, which is CBD, this shows some anti-cancer effect, which has been shown enhanced by radiation treatment. So when we used this CBD in a mouse cancer model, lung or pancreatic cancer model, this has been shown that reducing the growth of the tumor as well as increase the survival duration of mice. In other studies, which also we do see some combination of other drugs like immunotherapy further enhance this duration. So next, I would like to say some of the non-cannabinoid types of cannabis derivatives, which are non-psychotic also. Now, one of them are flavonoid derivative FBL03G from which also called caflanol, has been extracted from the cannabis plant. And this also has been shown a high potential for treatment of pancreatic cancer, which has been shown in animal model, also reduce the growth of the tumor with further enhancing the survival duration. as well as when we use radiotherapy in combination with these cafranol, the duration of survival increase. So this has some radio sensitizing uh, capability, and it also have some cancer uh, me- um, metastatic cancer treatment potential, which reduce the tumor progression. In another study in mouse model where we use nanoparticle based delivery of hesperidin, which is a flavonoid, non-cannabinoid type of cannabis, um, along with immunotherapy, anti-CD40. This also shows a very interesting effect when we use a lung cancer model. So tumor in the lung shows reduced in the growth in some cases. Few cases we also observe disappearance of the tumors when we use a combination of hesperidin as a hesperidin nanoparticle, along with a combination of an immunotherapeutic agent, anti-CD40. So we combine these two, hesperidin as a nanoparticle and antibody as a free format, to inhale by the mice, and then we observe the mice weekly basis, and we saw increased duration of survival with um, both hesperidin as well as hesperidin plus anti-CD40. But when we add the anti-CD40, the duration of survival further increased, which exceeded the alone treatment with anti-CD40. In our next study, we used another non-cannabinoid type of cannabis, which is a flavonoid, myricetin derived Linebacker 1, where one of the hydroxyl group was replaced by a chloride group to increase the solubility of this drug for better uptake. So in this study, we also observed that when we treat with Linebacker 1 in this lung cancer model, we do see reduce the growth of the tumor, and as well as increase the survivability. But if we add radiation along with further increases the duration, survival duration. And when we add radiation plus when we add um, anti-CD40, which actually in further enhance the survival duration, compared to the RT and anti-CD40 alone. And if we add radiation with Linebacker 1 with anti-CD40, we do see the highest survival duration, where it survived with around 60 days, but only LB1 survived around 25 days. So combining multiple drugs as radiation or um, immune checkpoint inhibitors like anti-PD-1 further enhances the survivability of the patients compared to the only anti-CD40 or RT or any other traditional combinations. So as we mentioned earlier, CBD also have some palliative effect in cancer care, which can be used for symptomatic management like pain relieving, neuropathic pain, nausea, vomiting, or other chemotherapy induced symptoms, and then increase the appetite of patients after taking the drug or any chemotherapeutic agents. So this has been shown well known for reducing this type of cancer-related symptoms. So in our next study, we wanted to verify scientifically if these actually have a potential for inducing some reducing the pain or neuronal stimulatory behavior for getting some quality of life in those patients. So in this case, we used a mouse model where the mouse become the tumor become like a bigger mouse become slow and just have a uh, depressed mood, just sitting somewhere, which called hunchback um, position. So we actually analyzed that the difference between hunchback position, which is the demarcation of the high pain, high quality, high quantity of pain in the for the from the tumor in tumor bearing mice compared to the mice which doesn't feel the pain. So even though in the same tumor bearing case they can move around. So when we do see these actually these flavonoids like cafranol reduce the tumor burden, as well as then we compare to a group of mice with this FBL, which is another version of cafranol with the vehicle. We do see when actually when we use the FBL, the pain bearing condition actually reduces. The mouse have less symptoms compared to the pain orient with the vehicle treated mice. So now we want to go a little bit about what are the methods we can deliver these to the patients. So as you heard earlier, there might be many ways you can deliver, maybe orally or other um, IV or other methods. But here I'm talking about how we can increase the sustainability of the drug delivery, like when if we can give the patient how with fewer doses so that the patient doesn't have the burden to take again and again, or in a easy available method or technology. So we tried to develop some kind of biomaterial based mm, uh, substance which can be injected directly to the tumor to reduce the tumor burden. We can have this as a solid capsule format, or we can have a gel format which can be directly inject to the tumor. Or in case of lung or other cancers which we have studied, we generated nanoparticle format from hesperidine and use method nebulizer method for aerosol delivery to the mice. And we this also, as I shown you the results earlier, these also have been demonstrated reduce cancer burden in lungs by using this as a aerosol technique. So now how we may need to learn a little bit about what are the mechanism, how actually cannabis works in some with some preclinical evidence. So it has been shown by several studies that it shows some pro-apoptotic effect, which actually um, what does this pro-apoptotic means? This means it induces cancer cell death. So the cancer cell can become die like by itself. Cancer cell when it can induced by the this drug, and then it also does anti-angiogenic, because for the growth we do need lots of blood supply for the cancer to grow, but it may reduce the tumor blood vessel growth, so it inhibits the tumor growth indirectly, and it also acts as an anti-metastatic agent to reduce the progression of the cancer. Here you can see more of its process of actions of these three properties. Like it reduce the growth, reduce the proliferation, and by autophagy and apoptosis it reduce the um, increase the cancer cell death, and angiogenesis induce mm, induce an inhibitory stimulation for the blood vessel growth to the cancer to the tumor area, which causes cancer cell cancer progression, reduce the cancer tumor growth because it doesn't have enough nutrient to grow. And for reduce metastasis, it reduce the invasion into the blood vessel for going further to different organs, where that's how it reduce the um, cancer progression. And moreover, it also induce immune surveillance and epithelial to mesenchymal transition. This epithelial to mesenchymal transition is also a process needs for the cancer metastasis. So if it reduce this epithelial to mesenchymal transformation, this process slow down the cancer metastasis. And moreover, it has some inflammatory effect where it induces the inflammatory process to um, kill the cancer cells, and cytostatic as well as cytostatic boosting. So with all those preclinical diagnoses, there are few cancer clinical trials are currently going on. These can be, these are, I found mainly two of the studies. They are showing as this one, their phase 1 and 2 trial aimed to evaluate the combined effect of side effects, and it's in the glioblastoma multiforme, which is a brain cancer um, treatment model, and the other is phase 2 trial aimed to evaluate the effect of CBD as a single treatment in patients with solid tumors. So this is interesting to see. We from this is going from the farm to bedside. So hopefully this will come. The results will come out soon, and more new clinical trials will start to helping for cancer care in different cancer models. So this is my 30 minutes almost over. So this is something I would like to share with you guys. Thank you so much for listening.
Thank you, Dr. Saida, for these very good presentations. And I will open the floor now to the participants to ask some questions. So I will start with Julius, who has asked which extraction app. I think this question relates to Professor David Caterere, where Julius is asking which extraction approach is more cost effective, and do some approach result in better concentration of extract?
Yeah, thank you very much for that. I think maybe he asked that question before I answered it, and I think I have answered it. It really depends on what you want to achieve, right? So you can then, you know, pay more capex, so invest in a instrument, and then you know that your operational is not so complicated. Or you decide you want to go for the cheap way. And in fact, that is why we invested in CO2, because that investment was to de-risk growers and also just people across the continent. And we are happy to provide that service. So not everybody has to invest in an extraction technology. We've done that for you already. So let's talk, and you pay a small fee, and then we get you the extract.
Okay. The second question was, where was the extraction approach used for cannabis used for this cancer study in animals? I think that's related to Dr. Saida.
So can you hear me? Yeah, so we use the extraction we bought from Sigma in oil dissolved formula, and then we prepared our own method using the SRB for slow delivery or um, or as a aerosol delivery.
So now I also had another question to Professor David Katerere. You mentioned that I think it's Kaninga, the mixture of cannabis and moringa, right? Am I correct?
Yeah. Mm-hmm.
I wanted to know, like, have you optimized the concentration of the ratios that you should have to have this specific effect? And if you have optimized this ratio, like, how do you make sure that you have reproducible extract having the different components, like in the specific concentrations?
Yeah, so we have optimized it, and that's an analytical chemistry domain, right? So we are able to show a COA for both the spent biomass and then the moringa before we mix it, and then obviously do a QC of the finished product.
Okay. So
Yeah.
is that something that is that is reproducible to any other phytomedicine plants? Because I know one of the challenge sometimes we've been asked when you want to use extract is like, how do you make sure do you all have consistently the same amount of active component in that? So is that something that is reproducible, or is that just specific to the product that you've been working with?
Yeah, that's an interesting question because these are plants. So, they are growing in different parts of the continent. So reproducibility is a difficult one. And that's actually why we have the African Herbal Pharmacopoeia, because part of that is how do we standardize these plants, maybe according to cultivar. The nice thing, of course, or for cannabis and for moringa is that these are cultivated crops. So already they are not, going to be all over in terms of the phytochemistry. And so with this Canaringa, we are using cultivars that we know and which are growing in specific areas.
Okay, thank you.
Yeah. I just
I
had a
will.
question and comment for sorry if I may, for Dr.
Yeah.
Said. Thank you very much. Very interesting work. Congratulations on that. But have you looked then at these, full FECO, right? Full spectrum cannabis oils, or are you just looking at, like you were talking about flavonoids, so just individual flavonoids?
Yeah, thank you very much for your questions, and that's very interesting. And I also liked your presentation, very knowledgeable. The one we use very specific is that since we bought from the drug company of chemical, so these are very specific chemical structure of each. Like hesperidin, when we buy in hesperidin, actually we bought in the powder format, maybe lyophilized, and these are very specific. LB1 also we received from the company, Prophase 1. So these are very specific drugs, not in combination with other drugs or anything.
Okay. Yeah, because I think would be very keen to try and see, how we can work together,
Yes.
particularly in actually trying to reproduce some of this work on the continent. because one of the things that I find is so cancer is is an increasing problem in our continent, but then cancer medicine is also very, very difficult to get hold of. So in
Mhm.
that's why cannabis is a game changer, because it means that every country can actually grow its own medicine. And as long as there's standardization that's being done according to use, but also according to the chemistry and the quality of the biomass, that could really save a lot of lives.
Yes, yes.
Yeah.
That is very, yeah. But when while we are studying, we found very interesting in combination with different or in aerosol delivery with the like almost some of the lung cancer totally disappeared. So that is very very interesting study. We would really love to study more with different types of cannabis. Yeah.
Okay.
Thank you. Yeah.
My other question to Dr. Sayeda will be with respect to your animal studies, right?
Mm-hmm.
So during my postdoc, I was investigating what's the most immunogenic dose of radiotherapy. So in order to do that, I have
Yeah.
like high dose, a medium dose, and I used to look at different regimen, what they call fractionated, when they give like a low dose over a over 3 days consecutively. My question now is, did you had this factor in consideration when combining it with cannabinoid to first identify what the most immunogenic dose, and let's see if combining that most immunogenic dose of radiotherapy with cannabinoid, we have a better therapeutic response? Was that performed already, this study?
Yeah, that's a very interesting question. So when we started, it was with Dr. Nagawa. It was like we don't know what is the dose, we don't know what is anything. So we actually started with different doses and fractionated, non-fractionated, with different. I think we started from dose 2 gray up to dose 30 gray. So we published this paper actually in 2017 and worked with Stephanie Dugan, which is an immunologist here. So in that study, at first we use these different doses of radiation with a single dose of immunotherapy to evaluate with or without immunotherapy how does it works with different. So we actually found that it's not too low. The two gray was okay, but not that good. And the 10 gray didn't give us as good as 5 gray. So figured out 5 grays, a single fraction of 5 gray works best in our hand with this group of mice. Then we further evaluated with different immunotherapeutic dose, and then later on we also use the same 5 to 6 gray around for different types of like other cannabinoids and other uh, drugs. So, but 5 to 10 is the ideal dose, I'll say.
Thank you. Dr. Carrillo?
Thank you so much for the presentation to Dr. David and to Dr. Saida. This was very important, and I am very honored and happy to be part of the group organizing this phytomedicines course from farm to bedside, because every class that we've been having is being very important for the students and for the people that is interested in this program. Last week we were talking about cultivation, and I was mentioning I am a clinician, and I've treated more than 2,000 patients with cannabinoids, and I have seen and I tell that definitely the process where the obtention of the medication is very important, such as that research, and if cultivation is very important, also extractions, as Dr. David mentioned, because as physicians we need to know exactly how the medicines that we're giving to our patients is being prepared, and that it has to have compliance with the governments, with the regulators, since we are giving medications to patients that are immunosuppressed or with neurological conditions. We have to be and remain cognizant that it is very important the medication we're giving to our patients meets the standards, and it has to be high standards because it's for the well-being of our patients. And highlighting something the Dr. David said that struck me, and this is the goal and the objective of this certification or this course, is that the lack of education for healthcare professionals. There is all over the world. I'm professor in 3-4 universities in Latin America teaching cannabinoid medicine, and I still see how from all over the world this need is a growing necessity to have more information. So thank you for that, Dr. David. And I have a question for Dr. Saida. A few years ago, it was a publication about the use of cannabinoids and immunotherapy in patients with cancer, and they were saying that physicians should not administrate cannabinoids where the patient is having immunotherapy. This publication then received a few commentaries because they were saying that it's just a particular type of immunotherapy. And then they published another paper where they're saying that depending on the type of immunotherapy and the type of cancer, is that the cannabinoids can be used or not used. I would like to know if in the university in Harvard or in Dana-Farber, and I know you're at the forefront in the research in here, there is new updates about use of cannabinoids and immunotherapy. Yes, using it or not using it. What will be your opinion? Because I know you're an expert in this field.
Thank you very much, Sandra, for this important question to bring it up. So yeah, yes, immunotherapy has a wide variety of drugs. In our study, our technique it, of the immunotherapy is different for the checkpoint inhibitor, which is most prolifically used immunotherapy. So in most of our studies, we used anti-CD40, which is an activator of the antigen presenting cells, those cells which can show the cancer, this is a cancer cell, to the body immune system, and then immune system will think this is a foreign body, and it will generate cancer killing immune cells to kill this cancer, to not only the local cancer where it has been treated, but also the further away metastatic cancer which not has been treated. So what this anti-CD40 helps here? It induces, when the cancer cells are, the first thing that when the cancer comes is it's actually slow down our immune system and then they do not uh, allow those cancer cells to be attacked by immune cells and destroyed. So the antigen presenting cells become non-antigen presenting cells, which we call M2 type of macrophages. In this case, when we combined radiation with immunotherapy, which is anti-CD40, the radiation generate apoptosis or breaking the cells to the cells dies, and it's broken parts, which is like not a normal cancer, normal cell or tissue parts in the body. Those are antigenic, like which is not the self persons. So the antigenic property shows into the activated macrophages or dendritic cells, which then induces the tumor killing mechanism, like enhance the anti-C, the CD8 positive and CD4 positive T cells, which will go and kill the cancer cells. So in this case, the purpose of radiation is to induce apoptosis to the cancer cells to enhance um, antigen productions. And so in our next study, uh, where we did used flavonoid, one type of cannabis, instead of radiation, because it has been shown that flavonoid also induce apoptosis. So without doing radiation, we just did the apoptotic action by by this hesperidine cannabis, and when it has been shown by added with the anti-CD40, we do see further enhance of the work. But in another study we have been done, where we combine different type of not the hesperidine, it is Linebacker, like myricetin derivative, where we combines at first with the same Linebacker one, we do see, yes, they have some anti, the myricetin is well known for also apoptotic work. So where we combine this myricetin along with the anti-CD40, we do see further enhancements of the, cancer destruction. And later on, we also did some adding radiation or anti-PD-1, which actually further enhances. We did not see any, contradictory effect in our studies. Yeah.
Thank you so much.
You are most welcome.
Okay, I have another question related to what Dr. Carrillo just asked. Have you performed any immune profiling or the different cannabinoid derivative to identify, first of all, are there any cannabinoid that are non-immunogenic, meaning like they don't have the capacity to induce immune response, and there are some that have better capacity to induce the immune response? Is that the context? And if this exists, have you ever done any immune profiling to see which one is the best to combine with radiotherapy, which already inducing immunogenic cell death?
This is for me, or?
Yes.
Okay, sorry. Yeah, so combining radiotherapy with anti-CD40, you mean?
No, like combining radiotherapy with the cannabinoid. My question was like, if a cannabinoid has the capacity to induce, first of all, are all cannabinoid derivative and non-cannabinoid capable of inducing the immune response? If they are all, which one is the best? Because my understanding is whatever is the best to activate the immune system should be the one that should be combined with the radiotherapy, right? Is that a
Yeah.
study that you've performed on performing immune profiling of this specific cannabinoid drug when treating mice?
We did work separately with each of them, but we did not do all together, like compare with each other, because if we do separately, maybe each of them might have a different variability, so I cannot answer this yet. But
Okay.
currently we are trying to do to get a much better effect, we are trying to do combining two types of cannabis, which can further maybe those apoptosis have different pathways to work with. So we are trying to figure out that combining two different types of cannabis which works with two different pathways, so that may induce stronger immunogenicity or anti-tumor effect.
Okay, thank you very much. And also, I wanted to ask maybe to Dr. Sandra Carrillo from a clinical perspective, like, is the route of administration drastically impacting the efficacy of the treatments?
Oh, well, definitely when we're talking about palliative care, like treating patients' pain and all the symptoms that Dr. Sayida was saying, like nausea and vomiting and the sleeping problems, the pain, the route of administration matters because the oral administration gives us a more steady levels for the patients that we can dosify every 8 hours, every 12 hours, and we can use sometimes the inhale route as a rescue when the patient has flare-ups, but mainly the oral route of administration is a better way to treat the patients because we can give them more consistency and more durability of the effects of treating the symptoms. And even during the night, the patient takes the night dose, and we know it could last like 8 hours or 12 hours. And if we give the patients an inhale route, we know the duration is going to be shorter, so the patient is going to be waking up or in more pain or suffering. But I don't dismiss the inhale route. Either way, the oral administration is for me the one that allows me to treat more efficiently the patient. The inhale route is very important when the patient has flare-ups or crises that the oral dosing is not able to control. So it definitely impacts the efficacy of the treatment, but you can combine. And in some cases, you also use the topical route for different types of pathologies, as Dr. David was showing, in particular the skin conditions and some types of pain. The topicals can be delivered effectively. Also, I find the topical route a very challenging route because the skin is a very complicated barrier to trespass. So all depends on the vehicles that you use for the cannabinoids in order to be absorbed in the skin. So yes, the root matters. Thank you for that question.
Yeah, so sorry if I may just jump in there. So suppositories are actually underestimated, particularly in terminal cancer, because at that stage a patient might not be able to swallow, they might choke, they might be nauseous, right? So we find that the use of suppositories, even though it's not always culturally acceptable, at that stage you actually want that. One of the other things that I've noticed is also the fact that, so when somebody is on opioids, they actually just end up a zombie, right? Because you're escalating the dose to a point where they're just sleeping, and then you get all sorts of complications, bed sores, hallucinations, you've got nausea, you've got constipation, right? All everything becomes really complicated. And yet what we're finding with cannabis-based medicines is that, number one, you also reduce anxiety issues, right? So the patient is not as anxious, they are sleeping better, they actually have, an appetite. They can at least eat something. They don't have nausea, they don't have constipation. So the quality of life when you use cannabis as a painkiller is better than the quality of life when you use the opioids. So that's actually, and again, what we were saying, that in a sense, it's traditionally acceptable. And in some cases, we just ask people to make teas. They can get cannabis, they can grow tea. And for me, at the end of the day, the whole cannabis movement is about access to affordable medicine. It's not really about anything else. And yeah, thank you very much for that.
Sorry, I just wanted to add something. And when I mean inhale root, I mean the flower used in medical devices. There is a specific medical devices for using flower. As a physician, I never recommend the patient to smoke, because we know the smoking or the joint that people call produces toxins that go to the lungs, and they can cause irritation and many other deleterious side effects. So absolutely, when I talk in the clinical context for a patient medical use, it has to be a flower that meet the standards of quality that every government and regulations have, and also prescribe under prescription of a physician, doctor, of healthcare professional, and using a special device. That there is a few medical devices that they are created particularly for inhalation, and then they heat the flower at a temperature that it doesn't produce the different toxins that can go to your lungs, or contaminants, if we want to call it like that. So it's a process that it has to be also considered.
Okay, thank you everyone again. We are approaching the end of the presentation and discussion, today's discussion, which is 9 minutes away. Thank you even everyone, to the participants who have been active and asking questions. Thank you to our panelists, Professor David Caterere, Dr. Saida Yasmin, and Dr. Sandra Carrillo for your comments. Next week, we will be having a module 4, and flyer will be distributed starting on Mondays. And we look forward to have you next week. Thank you again.
Thank you so much.
Thank you and
Thank you,
goodbye.
everybody. Bye.
Bye.